Welcome to Can I Butt In, the Bowel Research UK podcast, where we welcome bowel cancer and bowel disease patients, researchers, healthcare professionals and carers to butt in and share their experiences. We're picking a topic every episode and getting to the bottom of it. I'm your host, Sam Alexandra Rose. I'm the Patient and Public Involvement Manager at Bowel Research UK, and as a patient myself, I'm excited to bring more patient and researcher voices into the spotlight. Hi everybody, today we're talking about what you may like to call mini colonoscopies performed using a tool called LumenEye, created by the MedTech company SurgEease. SurgEease Innovations is a pioneering UK-based medical technology company that has created a point-of-care digital retroscope called LumenEye. LumenEye X1 was invented by a British bowel surgeon called Farid Iqbal and designed to improve the diagnosis and prognosis for patients with gastrointestinal diseases. So we'll be looking at the benefits of this procedure to the patient and the NHS and how it's different to other examinations. So with me today is Emilio Lozano. Emilio is a general surgeon. He trained and qualified abroad in Caracas, Venezuela. He practiced general and colorectal surgery in multiple healthcare settings in Venezuela, Spain and England since 2006. Emilio has a special interest in anorectal neoplasia, colorectal and general surgery in spinal injury patients and benign colorectal disease. He's a fellow of the European Board of Surgery and runs the video proctoscopy clinic using LumenEye at Stoke Mandeville Hospital. So Emilio, welcome to the podcast.
Thank you for having me, Sam.
We love to talk about new technology on the podcast. So yeah, it's a pleasure to be talking about this today. And I thought we should start just by explaining to those who are lucky enough to not have had flexible sigmoidoscopy or a colonoscopy before, what the difference is between the two. Because as I understand, LumenEye is an alternative to flexible sigmoidoscopy in some circumstances, but I don't think everybody is going to know the difference between a flexi-sig, is what we call it for short, and a colonoscopy. So could we start there just by sort of explaining the difference between the flexi-sig and the colonoscopy, please?
Yeah, so flexi-sig and colonoscopies are endoscopic procedures, involve using a fiber optic instrument. It's a long tube with a camera video capabilities, and also has some channels to insufflate air and to apply some suction. Essentially, a colonoscopy is the test used to investigate the whole large bowel. So the instrument is progressed from the anus to the right side of the colon, to the cecum, where the small bowel joins the large bowel, essentially on the right side. So it's a complete examination of the large bowel. It requires bowel preparation. It requires the patient to drink a strong laxative that flushes the colon out and gets the bowel prepared. Some patients find this a little bit unpleasant, but it's very important. Yeah, it's very important because that basically is what allows the endoscopies to accurately check the lining of the mucosa of the bowel for lesions. Is used for many indications, and most importantly for cancer detection. A flexible sigmoidoscopy uses the same instrument, the same fiber optic instrument, but it only progresses to the left side of the bowel, halfway through the large bowel. This is essentially a limited colonoscopy procedure. It's called flexi-sig. It addresses issues arising on the known issues of the left side, or when the symptoms are suggestive of a lesion on the left side, which is the most common reason for problems, mostly on the sigmoid colon. It can be done also with bowel preparation, or in some specific circumstances can be done with retrograde preparation with enemas, essentially, and some diet before. So it's the difference between the two is the length of colon assessed. In a colonoscopy, the whole large bowel is assessed, and on a flexible sigmoidoscopy is mostly the left side, the sigmoid descending up to the left side, or higher in the left side where the splenic flexure is. So that's essentially the main difference.
And it doesn't take quite as long, does it, to do a flexi-sig compared to a colonoscopy? I think it's a flexi-sig sort of around like a 10-minute, quite a short, because I guess if you're seeing less of it, it takes not quite as long.
Well, it's less corners to negotiate, and it's less unpleasant. It's not sedation is not necessarily offered on a flexi.
Yeah.
Whereas for a colonoscopy, usually painkillers and sedatives are given to keep the patient comfortable during the procedure. It could be quite unpleasant, particularly when turning the corners of the bowel. The bowel runs from the right side to the left, all across the abdomen. So it is sometimes unpleasant, and the insufflation is an absolute requirement to navigate the instrument inside.
So LumenEye then is an alternative to a flexi-sig, essentially.
Well, I will not say that it replaces, it takes place instead of a flexi-sig. The LumenEye is essentially an enhanced version of a well-known procedure, outpatient procedure in colorectal surgery called a rigid sigmoidoscopy. So there are two ways of exploring in the outpatient department, classical ways. One is the proctoscopy, which is a short tube just to have a look at the lower rectum and the anus. And the next step is a rigid sigmoidoscopy, which reaches distances of variable distances, but mostly about 15 centimeters. The low sigmoid and the rectosigmoid junction, the whole rectum and the upper anal, and the lower the upper anal canal. So LumenEye is an enhanced version of rigid sigmoidoscopy. So it's an instrument that has some features that allows better ergonomics and better biopsy capabilities than the traditional rigid sigmoidoscopy. It's an outpatient department procedure. It requires just a single enema for bowel preparation, and sometimes it can be done without if the rectum and the sigmoid are empty. But essentially that is it. It doesn't replace a flexible sigmoidoscopy.
Okay.
So it cannot look beyond that point. Some lesions, but most lesions are located, more sinister lesions are located in the rectosigmoid junction or the upper rectum. But there might be lesions further upstream that cannot be reached with the rigid sig or the LumenEye. So it needs to be carefully weighted when this is needed. The symptoms can guide which procedure to do. I think if it's available in the outpatient department, that gives an extra diagnostic capacity. But most patients will require a flexi anyway, or a colonoscopy.
Okay. And we'll talk a little bit later about who might benefit from having a LumenEye and flexi-sig and things like that. So in terms of the clinician then, so who can use the LumenEye and where is it currently being used?
Anyone with basic knowledge of or the skill to do a rigid sigmoidoscopy can use the LumenEye and will find it very, very convenient, very ergonomic. We currently basically use the LumenEye in many settings. Essentially, we started an outpatient clinic using the LumenEye to check response to chemoradiotherapy in rectal cancer, for example, where this patient had a colonoscopy initially, a diagnosis of a rectal cancer, and they had neoadjuvant chemoradiotherapy, which is the initial treatment for most advanced rectal cancers to make the cancer shrink before surgery. And these patients are followed up after treatment. And there's no need in these patients to use a very long instrument to check on a lesion that's known to be in about 10 or less centimeters from the anal verge. So in those cases, like freeing the endoscopy department pressures, on having a look at this, we can check with the LumenEye, document the findings, and check for the clinical response to this therapy, to chemoradiotherapy. So that's very convenient. So that clinic is running since 2022 and is about providing surveillance, close surveillance after radiation for advanced rectal cancer.
That's really good. Yeah.
That's the main use for LumenEye. Also, as part of a colorectal department, sometimes there is need for what's called tissue diagnosis. Let's say rectal cancer has been biopsied using a flexible sigmoidoscopy, for example, and the biopsy is not optimal because it's too superficial, and the pathologist could not see if there is any cancer or not in the area. Then these patients can be referred to the LumenEye clinic for further deep biopsies that can be done in the outpatient department. And we have found that with LumenEye, you can get deeper biopsies than you can with a flexible instrument. So that's another use. So for surveillance of rectal cancer, post chemoradiotherapy, for further biopsies when the diagnosis is not clear or there's no tissue diagnosis in suspected cancers of the rectum. There is also many uses. We normally use LumenEye in theaters, where we can check the position of the tumor during a robotic or laparoscopic procedure, a rectal resection. Then the bedside assistant can check the position of the tumor using LumenEye, which is very ergonomic, given the patient is all covered in sterile dressings, and even with the robot, you have the robot on top of the patient, so it's difficult to access that area.
Yeah.
LumenEye gives that advantage, and it gives the advantage of all the team members being able to see where the tumor is, and to see that we are below the tumor to take it all out. So that's one of the and measuring the distance of the joint. If we're going to join the bowel with the rectum, it can be measured with LumenEye in a very convenient fashion. So that's another use. Also about checks for many other indications, particularly for spinal patients, and check for proctitis, polyps, suspicious lesions of the anus and rectum with the LumenEye. So it's a very convenient, and the possibility of documenting, to have a graphical picture or a video of the findings is very, very useful and very convenient. So it's a great advantage to have this device.
Yeah, that sounds like loads of different applications. That's really cool. Yeah, because I didn't know about sort of the deeper biopsies and yeah, checking during robotic surgery. That's really interesting. And I can see the benefit for the patient as well, because like you say, if you know where the polyp is and you can access it with a less invasive procedure, why put the patient through kind of a larger colonoscopy if it's not sort of necessary at the time? You can get it an easier way. Yeah, definitely.
Exactly. These patients, the ones I was telling you about surveillance of rectal cancer, need to have, according to the protocol, is to do a side check, a rectal check, every 3 months for 2 years.
Right.
So that's really high frequency, and
Yeah.
And the target was not fulfilled because there was no capacity in endoscopy to do this frequency, and the patients needed to attend, and it was very, very difficult for them to follow up, to give enough appointments for these patients. I work in a high volume center, so there are many patients having this treatment. And in this clinic, using the LumenEye, we can follow them up better than before. So we have noticed that patients are followed on time. And if there is any doubt about the clinical response, then we can biopsy then and there. It all stays within the MDT environment, and we can all discuss about the best way to manage these patients if they don't respond.
So with a flexible sigmoidoscopy and colonoscopy, you can not just see everything, but you can also like biopsy and take a sample, and that can go to histology to be checked. I guess LumenEye is the same, that it can take those biopsies as well.
Yeah, so it has a working channel. and deep and large biopsies can be taken using it. The fact that it directly faces and is directly controlled, is a rigid instrument, allows for more deeper sampling of an area in the rectum. It has some disadvantages. It cannot bend. The rigid instrument, it cannot bend sideways. And sometimes lesions that are behind folds in the rectum cannot be checked. But in those cases, we basically have good communication with the endoscopy department. If there's any doubt, then we get a flexi. If it's something that's beyond the reach of the equipment, then flexi helps in those situations.
Right, because sometimes things we spoke, just breaking the podcast fourth wall for a second here. When we had our conversation a little while ago before recording, we spoke about how sometimes there's a polyp sort of quite low down near the rectum that some instruments can't actually sort of bend that way to pick them up. So you have to have quite a specific instrument for that.
Yeah, it can be done also with flexi, but I think it's a bit more difficult. I think the access to the lower rectum and the upper anal canal is easier when looking straight, not coming from top.
Mm-hmm.
So there's a way of flipping the tip of the endoscope in the form of a J, so called the J maneuver, flipping and looking downwards into the rectum. And sometimes some polyps can be removed that way, but it's not easy, and sometimes it's challenging. Sometimes the polyp encroaches into the anal canal, which is not visible. So in those cases, I think a video proctoscopy is useful. But the convenience for the patient, convenience for the surgeon. So in secondary care is very useful.
Absolutely. It's really interesting just finding out how all this stuff works, being the person who's normally on the receiving end, if you like, of this sort of procedure. It's good to get an insight on it. So I'm just interested, I'm taking us off track a little bit here. I'm just interested in the deeper biopsies. And so when might you need to take a deeper biopsy? What kind of situation would that be?
Well, when the patient gets an initial, these biopsies, the endoscopic biopsies, are usually no larger than 2 millimeters, so they're quite small bites. And these lesions can be a few centimeters, could be 5, 10, 8 centimeters long, and not all. Most of them arise from a polyp, which is like a wart type growth on the lining. The cancer is not symmetrical and may happen in a part of the polyp. The invasion could be in one side, not necessarily symmetrical. So if a biopsy is taken from an area which is still a polyp, it will show just some changes and it will not be conclusive. And the biopsy is needed for different analyses and to check for the suitability for certain types of treatment. So it's important for the oncologist to have tissue diagnosis. So it is the ultimate confirmation that there is a cancer. That, along with other tests, it's not just the luminal visualization. It's also MRI scans, CT scans, to check for the spread of the cancer in the rectum. So deep biopsies are needed to obtain enough tissue for the pathologist to give us an answer, a definitive diagnosis, the tissue diagnosis, which is what says it is a cancer.
Right. So I guess you sort of always want a deep.
Yeah, no. Sometimes the biopsy, endoscopic biopsy, it suffices is enough for a tissue diagnosis. Sometimes it isn't, particularly when it's a low lesion and it cannot be sampled properly with a long flexible instrument. In those cases, the biopsy can be achieved with LumenEye and can be achieved in the outpatient department.
Okay. Can we just touch sort of briefly? I know it's not quite your area because you're hospital based, and we might do an episode later on as well with another guest about the use of LumenEye in CDCs or community diagnostic centres. But can we just touch on that, because I know that that's somewhere else where that's being used, and what is a community diagnostic centre, and can we talk a bit about sort of like the benefits of doing it there as well?
Yeah, so there are different There is a lower GI cancer, established lower GI cancer pathway where patients get referred to secondary care for investigations to rule out colorectal cancer. Some of these referrals are based on, most of the referrals are based on screening tests, stool tests, which basically picks up small amounts of blood in the stool, which is often invisible to the patient. It could be nanograms of hemoglobin mixed with the stool that gets picked up by this test. And then the patients who has a certain amount of blood can be referred to secondary care for additional investigations. Most often, the investigation is a colonoscopy. The patient can tolerate it, and essentially, it is a screening tool into the pathway to know who will benefit from an invasive investigation. Other referrals, other parts of the referral are patients who are having rectal bleeding. Rectal bleeding that could be clinically bright red, could be painless, could be painful, and sometimes is a clinical suspicion of the GP when doing a rectal examination, a digital examination with a finger, checking for masses or lesions in the anus or the rectum. So most of the time, these are very basic physical examination findings, and sometimes these referrals are, in a way, not appropriate because if there was an additional way of looking at the area or taking pictures, then I think the diagnostic accuracy of the GP in the community will be enhanced for this pathway. So I think it can add an additional way of checking that area or that particular area of the pathway. In the community, I think it will definitely not replace a colonoscopy as a gold standard for investigation. And in some cases, some rectal cancers can be picked up if they're low enough, can be picked up by the LumenEye. If it can be done in the community, those will be picked up. But there might be some rectal cancers that are missed because they're higher up, cannot be seen with the LumenEye, need to be checked with the Flexi. So it's in a particular set of patients with negative or borderline tests of blood in the stool and particular symptoms which are suggestive of a lesion that's low in the rectum. Those are the ones that will benefit from the rectal examination with a proctosigmoidoscopy, a rigid proctosigmoidoscopy.
Okay, so patient has potential bleeding or sort of some of the symptoms that you just talked about, and they go to their GP. And instead of referring them to the hospital immediately for a colonoscopy, quite an invasive procedure, instead the GP can send them to the CDC, the Community Diagnostic Centre. Instead, they can have a LumenEye. It's less invasive. It's one less person who's having to go to the hospital and be added to that waiting list in the endoscopy unit. And it could be potentially closer to people's homes and a little bit more convenient that way as well.
Yeah, so rectal cancer can be ruled out.
Yeah.
Or lower sigmoid cancer can be ruled out. That's an investigation that there's no tumor in the rectum and the sigmoid and the lower sigmoid, and there are large hemorrhoids or any other benign pathology. So that patient can be diverted to the colorectal outpatient clinic and not necessarily to a suspected cancer clinic. So this patient may still need a Flexi or a colonoscopy, but it doesn't need to go straight into the pathway. To be diverted to the right, on the right pathway, the right route. So that's essentially, I think, the advantage. Given a diagnostic tool that can be used at this community center, so trained personnel can do this test. Even the GPs themselves can do this test. They can learn and train. They can share the findings, which are video or pictures, and then fine tune the referral. And have more capacity to diagnose. And if they find a big lump or a big cancer, then that abbreviates the process of referral as well.
Yeah. And yeah, as you say, the secondary care or the hospital then has more information from LumenEye than they would have if the patient had just been referred straight from the GP as well.
That's correct.
So yeah, lots of benefits. And yeah, we've mentioned no bowel prep needed with the LumenEye as well, which I've highlighted in my notes because that, as a patient, is always a bonus, just having to do an enema
Yeah, there's no
instead.
laxative involved, but
No laxative, yeah.
in this clinic that I was telling you about, the surveillance clinic for rectal cancer, we routinely give an enema because we need to have a very good look
Yeah.
at the lining at the site where the tumor is or was burned by radiation, essentially. And then that requires the rectum to be very clean. So we routinely give an enema, which is a way of, it's a rectal preparation. The patient gets an enema, open the bowels, and the rectum is very clean. So with the LumenEye, you can have a very close look at the lining. Because all depends, in all any endoscopic procedure, the success of the test is reliant on the bowel preparation. If you cannot see anything, then the diagnostic capabilities are decreased. Essentially, you cannot see anything, you cannot biopsy, you cannot check. There are, even with colonoscopy, there are blind spots. There's areas of the bowel is irregular. It's a muscular tube and it's irregular. So there are folds. There are areas that can not be easy to check. There are many bends. So even with colonoscopy, even with good bowel preparation, there are some lesions that could be missed. It's tricky, and it requires a significant amount of training. For a rigid sigmoidoscopy or LumenEye, the training shouldn't be that long. It's a more straight area, and there are less bends, and the instrument is a bit simpler and easier to manage. So I think, with regard to training in these centers, advanced healthcare assistants, advanced nurse practitioners, GPs, any person who has a basic knowledge of anorectal examination could do a rigid sigmoidoscopy. It's a combination of rigid sigmoidoscopy and proctoscopy, so it can be done in the community.
That was going to be my next question, actually, was the difference for LumenEye for the person who's actually doing it. Because yeah, again, sort of being a patient, you don't really think about how easy is it to drive a colonoscope, how easy is that, and sort of to navigate sort of the bends and things like that. I don't know if I might quite like to have a go.
Oh, it
Strange
requires
thing
a
to say.
significant amount of training and
Absolutely,
practice.
yeah. But I mean, is it, you sort of touched on how it's easier doing a flexi-sig or a LumenEye with than a colonoscopy because it's sort of a smaller area. I mean, is there a difference in the tools? Is one more comfortable than the other and that kind of thing, or easier to use for a long period of time? Because I guess if you're in clinic, you're doing this over and over and over again.
Yeah, so you get significant if you work in a colorectal department as a basic part of the examination of any patient with this type of symptoms. With regards to endoscopic procedures, that is different. It's more complex. It requires an endoscopy unit. You require a significant amount of equipment and assistance, and the procedure basically is technically challenging. It could be even challenging for very expert endoscopists in some cases. So that's a different. I need to be someone very well trained. Now, for assessment in the community, the GP surgeries or the CDCs, the rigid sigmoidoscopy, the proctoscopy is a great advantage. I don't think training will take a long time.
Yeah. And LumenEye, as you said, can be done in conjunction with other tests at CDCs as well, can't it? You mentioned MRIs and blood tests and that sort of thing. And I believe that some of these centres now, you can go and kind of get all of that done at the same time in the same appointments. That's just one trip instead of, maybe 3 or whatever for the patient.
Yeah, so it's a process called staging. So the process is about getting some tissue diagnosis, getting some samples from getting a sense of the depth of invasion of the rectal wall. That's done with an MRI scan, rectum, magnetic resonance imaging scan of the rectum, and there's also need to do a CT scan to check for distant spread. Usually these cancers can spread most to the lymph nodes, can spread to the liver, the lungs, and can give metastasis. So basically that's a cardinal feature of a cancer. It can metastasize, can give it can travel in the lymph nodes, in the lymph glands, and then can spread via lymph or via the bloodstream, and can seed other distant organs, so distant metastases. So it's very important to do staging. If it can be done in one single place very quickly, that's very, very useful.
Yeah, absolutely. And so in terms of patients who could benefit from this technology, and we touched on this already, but again, in sort of our previous chats, we've said that it might not be appropriate for people with high risk symptoms like weight loss and things like that. Can you tell us a bit more about that?
Yeah, so there are significant cardinal symptoms of cancer. So a patient has had significant changes in the bowel habit, for example. They were perfectly regular, and then suddenly started having diarrhea with mucus, and then they started noticing blood in the stool themselves intermittently, some abdominal discomfort that's unusual, and they unexpectedly start losing weight. And they decide to do the QFIT, and then in the QFIT test, the screening test of the stool, and the FIT test comes back positive, and or the patient develops a new anemia, for example. Then that patient will be better served with a colonoscopy, just as the whole bowel, because there might be a tumor, and the tumor could be anywhere. If it can be readily assessed in the outpatient department with a SurgEease or LumenEye, then that segment is basically clear. So you can say, well, there's no rectal. If they found a big lump, this patient has a rectal cancer. It may still have cancer. It may still need a colonoscopy, but at least the diagnosis of the rectal cancer is done there and there.
Yeah.
So that's something that is basically an extra diagnostic tool. So most patients with cardinal symptoms and with strongly positive or very positive screening tests, those patients most of the time need a colonoscopy. And the LumenEye or a proctoscopy won't be enough to check. It could exclude rectal cancer or anal cancer, but it cannot look anywhere in the rest of the bowel.
Sure. And it's the same for people with genetic condition, isn't it? Like Lynch syndrome, for example, if people have to go to regular surveillance to check for colon cancer, obviously you need to check the entire colon. So again, you would want a full colonoscopy for if you had Lynch syndrome or something like that.
Exactly, and there are also there are enhanced versions of colonoscopy with dyes to check and pick up small lesions. So I think the colonoscopy in those cases is an absolute requirement, and usually done in very referral centers, and it enhances the diagnostic capabilities. So there are different. The new colonoscopes had many diagnostic features, such as dye spray. They can use basically light changes in the light, narrowband imaging to check for superficial lesions that may not be apparent to the naked eye, and they have very, very high resolution, so they're very, very, very accurate. So I think in those cases, in cases where you are doing surveillance for Lynch or for polyposis, I think it would be a good idea to do a colonoscopy.
So we've kind of talked about this already, I think, the difference between a flexi-sig and the rigid versions. I mean, are there any other differences between the two in terms of like collecting biopsies, or do you know the difference for the patients in terms of like going through a flexi-sig or LumenEye in terms of?
It's very, very similar. It's very similar. It's about the reach. So the flexi will reach higher up.
Yeah.
That's essentially the main difference. The rigid, the LumenEye will reach no longer than 15 centimeters. It will be the lower sigmoid at the most. It cannot bend. It cannot look sideways, sometimes behind folds. So that's a limitation. But the procedure itself is very similar. The position of the patient is very similar. The preparation could be done with retrograde preparation with enemas for both, and it doesn't require sedation. So it's similar, but it's about the capacity of the endoscopy unit.
Yeah.
to offer high volumes of this. It's something that's available in the outpatient department or in a CDC. That's very, very convenient.
Yeah, I think it's great, and yeah, especially sort of all the benefits of going to the CDC and secondary care, then having that information when if you do need to go for a colonoscopy, and yeah, sort of reducing the wait times and all that sort of thing. Yeah, it sounds very good, and all of the purposes that you mentioned before as well for robotic surgery and things like that. Yeah, quite a flexible tool then.
Yeah, doing intraoperative checks of the rectum, of the joints, anastomosis, and very convenient. Also for examination in theater when you're doing a procedure, you can use to check inside, reach up to 25 centimeters, and even under anesthesia, it can reach even further.
Okay.
So that's also something that can be used in theater.
How come it can reach further when you're under anesthesia?
Oh, you can reach further because there is less discomfort when you reach.
Sure.
You can press harder
Yeah.
without causing discomfort.
Yeah. Excellent. Final question for you then is sort of what are your hopes for the future in terms of how people are referred and tested for bowel conditions? What sort of one takeaway would you like to leave us with?
Yeah, so I think, well, the video proctoscopy would be a plus for the outpatient, basically assessment of patients with boring symptoms, particularly rectal bleeding. It can be done as part of the physical examination before referral. Most of these patients will need a flexi or a colonoscopy. The patients that will end up having a big malignancy of the rectum can be diagnosed straight away. If it's not clear to the finger or under digital examination, it can be enhanced by having a look. I think that is something that would be very convenient to have, and to have that diagnostic accuracy from the start and then in the community. Again, it will not replace the endoscopic assessment, but it's it's an extension of your clinical the capabilities for clinical exploration in primary and secondary care everywhere. With regards to the pathway, I think the pathway needs to continue. I think is very important in order to pick up. We know the survival depends on the stage, and then need to pick up cancers, colorectal cancer early. The main take. So I think the pathway should continue, and the most unexperienced people in the community can make the pathway more efficient. So the patients that has hemorrhoids or fissures or they don't have a mass, those patients can be taken off the pathway. They don't basically get additional endoscopy capacity, and patients that doesn't really need it. So that's something that can be also adjusted by having this available.
Brilliant. Thank you so much for coming to talk to me about this, Emilio. It's always really great to hear about sort of new technologies and how they can benefit patients and all of the research that's been done in that area. So thanks very much for coming to chat to me.
Thank you for inviting me, Sam, and thank you for having me.
Thank you for listening to Can I Butt In? This podcast was brought to you by Bowel Research UK. Find out more about the charity, our work, and how you can get involved. Visit bowelresearchuk.org, where you can join our People and Research Together network, or PART, read about our research campaigns and fundraising, or make a donation to support the vital work we do. Let's end bowel cancer and bowel disease.